Hello and welcome to Migraine Headache Awareness Week. My name is Anik Grundy and I'll be your host tonight. Tonight's webinar is on side effects of medications with Dr. Michael Eller. So Migraine Headache Australia is a division of the Brain Foundation, and our mission has three pillars. Firstly, to provide trustworthy and reliable information, such as our website articles and resources like this webinar. Secondly, to fund research into migraine headache disorders. And thirdly, advocating and supporting people who live with migraine and headache disorders. We're also highlighting different aspects of our advocacy, media, and recent events. And we've covered a lot of the photos on this slide, but tonight we are focusing on this one in the bottom right-hand corner. So this is from the Brain Health and CTE Summit a couple of months ago. There were some fantastic presentations on dementia, brain health, CT, which is chronic traumatic encephalopathy, and concussion. And while these might not seem directly related to migraine advocacy, it actually is all quite interconnected. I'm sure that many people have experienced, post-traumatic headache after hitting their head, or even possibly your migraine worsening after a head injury. So it was wonderful to connect with experts, advocates, and people in the community about the connections between brain health and concussion, migraine, and many other brain conditions. So next, I also wanted to highlight our advocacy toolkit. This is a wonderful resource if you do want to get involved in advocacy and maybe sharing your story with your local MP or a journalist. And that is the URL is linked on the slide there and can be sent in the chat, or you can search our website for it. And it's got basically a step-by-step process on it of everything you need to know about how to get involved in advocacy and some letter templates and other resources. And next, I'd just like to thank our sponsors. So that's AbbVie, the Brain Foundation, Pfizer, and Lundbeck. This event wouldn't be as great as it's been so far without them. So thank you so much to our sponsors for their support. So next, who is this for? You're in the right place if you either live with migraine or headache disorders, you're a parent, partner, or caregiver, and generally if you're interested in the side effects of different migraine and headache medications. It's also an opportunity to ask questions to an expert and connect with others like yourself. Speaking of connection, if you do want to join a migraine and headache support group, we do have a support group on Facebook. It's a really inclusive and welcoming space. So if you are on Facebook, we'd encourage you to join. It's a really wonderful community. Now to introduce our speaker for tonight, Dr. Michael Eller. Dr. Eller specialises in managing headache disorders such as migraine and trigeminal autonomic cephalgias, such as cluster headache. And he also looks after general neurological disorders like vertigo, cognitive problems, multiple sclerosis, neuropathy, and epilepsy. And between 2012 and 2014, Dr. Eller was working in the US at University of California, San Francisco, with the UCSF Headache Centre, working under Professor Peter Goadsby. So he conducted clinical and functional neuroimaging research and also maintained a headache clinic. He's previously worked as a visiting specialist at Royal Darwin Hospital, and he's currently at Monash Neurology in Melbourne. So he's bringing a wealth of experience to this presentation, and we're really excited to have him here tonight. Next, I'd just like to introduce myself, your host. My name is Anik, and I'm the Grants Manager and Digital Lead at the Brain Foundation and Migraine Headache Australia. I write a lot of our website articles and newsletters, and also am involved in our awareness weeks, such as this event, Migraine Headache Awareness Week, and also Brain Awareness Week. And you may notice that I have swapped roles with Carl tonight. So Carl Cincinnato, the Director of Migraine and Headache Australia, will be moderating tonight's webinar. So you'll see him in the comment section. Carl lives with migraine and he's a passionate advocate for people living with migraine and headache disorders. And he's done a lot of incredible work raising awareness both in Australia and overseas. So without further ado, I'll let Dr. Eller get started with the presentation.
Thanks so much for asking me to talk for Migraine and Headache Awareness Week this year. It's always a privilege. My name is Michael Eller. I'm associated with Monash University and an experienced headache neurologist. We're going to cover medications and their side effects. That's a really broad remit. It'll just be in association with things for migraine. And we'll cover things like the side effects that you can expect from the different buckets or types of treatments we use in migraine. So one bucket, acute medicines, what you take when you get a worsening or when you get a migraine, if you're only prone to them occasionally. Another bucket are preventives, so people who have high frequency headache predisposition and need to be on treatment more regularly to try and stop them coming in the first place. The other bucket, which are transitional therapies, therapies that we use to break the headache cycle or treat comorbid medication overuse. I'm not going to cover it all today. So they're hospital treatments and other interventions. So we'll broadly cover the likelihood of a problem, the relative danger of different side effects, the relative amount of knowledge that we have about a specific side effect and its likelihood. So there are some newer treatments where we have a great deal of data, such as the CGRP monoclonal antibodies. And there are other, but we've only been using them for a few years, while there are other treatments where the primary data is actually relatively poor with very small studies, but we've been using them for decades, things like propranolol. And we'll also cover any confounders. So things I won't cover today include pregnancy, breastfeeding, natural therapies, devices, procedures such as nerve blocks, placebo-nocebo responses, and specifically what treatments we use and when. In the next slide, I will cover some aspects of selecting medicines, but only in the broad. So considerations in prescribing, we always look at the safety profile of a prescribed drug, and your doctor should be talking you through the potential side effects, the ones that are more dangerous, that are uncommon, the ones that are less dangerous and common. And it's always a conversation around what a patient is willing to risk, because maybe the things that they're willing to risk are different to what you think they should risk, for example, because it's an individual decision. And we also talk, and also just not doing stupid stuff. So, if someone is prone to fainting, had lots of faints as a teenager and always runs with a low normal blood pressure, me starting a new medicine that can lower blood pressure, probably not the right move. It's not going to be well tolerated. And we'll also look at the overlap between a lot of the side effects of some drugs or perceived side effects and how that can be difficult to tease out from migraine symptoms themselves. I mean, most people watching this will know that migraines can have a really variable phenomenology, and even for people who have a sort of regular stereotyped migraine, there's usually differences in between. You get more severe, less severe, longer, shorter, and there are many non-specific side effects associated with that, such as tiredness or fatigue, difficulty concentrating, nausea. Many of these can be attributed to medicines, and they can be attributed to migraine. Often it's a combination, and sometimes it's hard to tease it out. But the typical thing is, this is why you need to usually try, at least when it comes to acute therapies, you need to try it a few times. A, to see how reliable it is. B, to see just to tease out those side effects from the migraine itself. So this is a table from a review I wrote for MGA a few years ago. There are other reviews available in Lancet Neurology, for example, or New England Journal of Medicine. which have even more information and prettier graphics. We'll cover each of these in turn, and then we'll get on to the preventives. So non-steroidal anti-inflammatory drugs, they'll be widely known to you. They include things like ibuprofen, Voltaren, naproxen, widely used over the counter, but they can be prescribed as well at different doses. The main problems with those drugs is when they're used intermittently, they can often make some symptoms such as nausea worse. They can add to reflux. They can be very poorly tolerated. If used very regularly, they can amplify bleeding risk. And longer term, for people who are using things like Voltaren for decades, for example, but same goes for ibuprofen or naproxen, it does put people at risk of amplification of their cardiovascular events. So, if you take Voltaren for 30 years, you are at higher risk of a stroke or a heart attack than someone who wasn't doing that. There's also a risk of a kidney injury with these drugs. Triptans themselves can tend to be well tolerated, but very commonly, probably at least half people can just feel a bit bombed out in a rather non-specific way, just not themselves, not quite right. The cognitive gears aren't clicking through quite as swiftly, and they can feel a bit drowsy. Very rarely you can get chest tightness, maybe 1 or 2% of people, or tightness of the jaw, that kind of experience. The chest tightness is thought to be attributable to esophageal spasm. It's not a cardiac phenomenon. Uncommon, sometimes a class effect. So if you experience it with elatriptan, maybe you'll have it with rizatriptan as well, or maybe it'll just be one and not another. All drugs can cause anaphylaxis, of course, not just triptans, but any of them. Anaphylaxis is swelling around the tongue, around the mouth, sometimes with rash associated with it, or change in blood pressure, can be life-threatening. Any drug, any food, anything almost in the world can cause that. Dopamine antagonists are another group of drugs that we can use acutely in migraine. You probably won't recognise that terminology, but it's medicines typically used for nausea, such as metoclopramide and prochlorperazine. They're drugs that in 20 to 30% of people can cause a symptom called akathisia, where you just feel restless and uncomfortable. You can just move a bit around like that. Often you won't be warned about that. You may not realise that was the side effect. You may just think, oh, that was the migraine and I felt like rubbish. Rarely that can be a bit more impressive with dystonic posturing, which is very uncomfortable, or Parkinsonism. If you use them very regularly, you can be at risk of some of those problems in a more progressive way. There's a new class of drug called GPANTs, which we'll come on to later, but nausea they're typically well tolerated, but can have drug interactions, which we won't cover today. Always talk to your pharmacist about that. Nausea seems to be the most common problem with it. This is the second bag, preventives. I'll spend the most time on this, and I'll go through each of the different classes of drug individually in a moment. 2 slides first, just to get you a feel for this. So you might think, well, why the hell do we prescribe all these repurposed old drugs? Well, beyond the fact that under the Pharmaceutical Benefits Scheme, to get into the newer, typically better tolerated medications, with better data, you need to fail or be intolerant to 3 migraine preventives and fulfill some other criteria. That's part of the reason we try, but also they can be effective in people. This is a study going back 8 years, asking people with migraine what their willingness, this is like a few hundred people that were surveyed, what their willingness to take a particular medicine in relation to how much of a headache frequency reduction it'll be. So basically, if you had a perfectly effective drug, how willing would you be to put up with potential side effects? The nomenclature is a bit odd for some people, or for Australians. Divalproax is sodium valproate. but the other medications you can see there, gabapentin, propranolol, topiramate, venlafaxine, they'll be familiar to people in Australia. And you can see from that is, the people are relatively more willing to trial topiramate or gabapentin, and they're highly unhappy to try sodium valproate. So only 25% of people would be happy to trial sodium valproate, assuming it was 100% effective. There you go. We know this. We also know that most people stop taking medicines. So this is an analysis of thousands of people in the States followed by insurance companies. So, you can get really nice tight data on that. And look at this at the 3-month, or even after 1 month, almost half of the people are not taking preventives. And at the 3-month mark, it's down to about a third, and going out to a full year, we're getting into something like 15 or 20%. So, and the curves are similar, whether they're beta blockers, anticonvulsants, antidepressants. So this is what we know. So, neurologists like me know that people will try stuff, but they'll more often than not, stop it. And we don't hold that against people, And that doesn't really tease out whether it's going to be effective or not. So some people will have side effects, stop the drug, even if it was effective. So getting into the different classes of drugs, and this is going to be a pretty rapid tour. Pizodopin can cause weight gain and drowsiness. So that's a downside to that drug, even at relatively low doses. Tricyclic antidepressants, such as nortriptyline and amitriptyline, can cause anticholinergic symptoms like dry mouth, dry eyes, constipation, weight gain, drowsiness, dyscognitive symptoms. So people can feel a bit drowsy in the morning, just the gears don't click as quickly. Like the last person I saw this afternoon, they didn't feel good on nortriptyline at all. Now, I'm just going to emphasize this point again, and sorry if I labor this, just because they're potential side effects doesn't mean you're going to get them. It's hard to pick. Anti-epileptic drugs, topiramate, common side effects include, that should read acral, so ACRAL rather than oral. That means the hands and feet, you can get pins and needles, you can get altered taste, dyscognitive symptoms. Less commonly, you can get some weight loss, though it's usually relatively minor. The doses we use, irritability, exacerbation of anxiety. I worry about the use of that drug in people who already have challenges with anxiety already. It's a rare, dangerous side effect called acute closed angle glaucoma. So you can develop raised pressure in the eyes, and typically within the first few weeks of going on to the drug. And if you haven't warned a patient, they may not realize that's an issue. Patients usually clue in because they can get some blurred vision, altered vision, and the eyes feel weird and uncomfortable. Need to go to the optometrist quickly on the day that you realize you might have that, and get your pressures checked and stop the drug as soon as possible if they are raised. Kidney stones can sometimes occur. Suicidal ideation has been described with that drug. Sodium valproate, we touched on briefly. There is a long list of rather unattractive potential side effects, with a caveat that, in older people, for example, it tends to be incredibly well tolerated and, and very useful. So, not a drug to discard, but a drug with a long list of unattractive side effects, such as weight gain and drowsiness. Angiotensin receptor blockers are a class of drug that tend to be relatively well tolerated, can lead to some lightheadedness, exercise intolerance, very rarely kidney dysfunction in the early period where you trial it. So you need to have electrolytes checked prior to and after 2 to 3 months of being on that drug, just in case you have a rare variant of your kidney anatomy which predisposes you to a problem. Beta blockers, also widely used, that can lead to feeling lightheaded, exercise intolerant. Your blood pressure can dip If you're prone to bronchospasm, you can get wheezy on the drug. It's the opposite of what your puffers do, and rarely people can develop nightmares or erectile dysfunction. Flunarizine is a drug less familiar to most of you probably, but it's an old drug that can hit a number of different receptors, such as it's a calcium channel blocker with serotonergic and dopaminergic activity. It can contribute to drowsiness. That's usually the most common problem. Rarely weight gain that can occur, even more rarely Parkinsonism or uncovering restless leg syndrome symptoms. And in people who've had troubles with depression in the past, especially really problematic depression, I'm very wary of using this drug because it can make that worse. This is a graphic that screens calcitonin gene-related peptides. It's a familiar topic for many of you. There are a few different classes of drugs, and I'll skip through them relatively lightly without labouring the pathophysiology. Not today. So this is a slide describing arenimab, and we've got the best data for arenimab in terms of safety because it's been around the longest. That's a CGRP monoclonal, and that's a CGRP receptor antagonist, the canonical receptor. And the reason I've put this here is of the 376 people that were enrolled in this trial, at the 5-year mark, 268 138 are still using it. So there's drop off. But when you look at the reasons people have dropped off over that period of time, and they could be any number, these people offered free drug in an ongoing sense. And it's a bit hard to read, so I apologise in the slide, but in the right-hand corner, you'll see that, rash is really rash is one thing that's occurred, but there's minimal other there's not a lot of significant stuff that has made people stop, very overlapping with placebo, essentially. And that's a similar thing with all the other MABs, when you look at side effects, relatively low rates. So just drilling in a little bit more, alluding to some other studies, and we've got more and more data around these things. There's a FDA warning around hypertension with arenimab, and a few isolated case reports, which led to that. We're still open whether that's a real problem or not, but we look out for it. I've seen one person where I was convinced aranimab led to hypertension. Constipation is more likely than with the other injectable drugs. This is a slide to talk about most bothersome symptoms in people with migraine. They happen to be treated with eptinezumab. But, like that slide showing the different phases of migraine, you can see many of these non-specific symptoms like mood change, fatigue, and dizziness are common with migraine, just like they can be common with many medications. The most common thing that we warn people around CGRP pathway medications, such as fremanezumab, eptinezumab, galcanezumab, local site reaction, probably the most common thing, which can be a red welt, often itchy, usually the day of the injection, the day after, runs for a couple of days. Occasionally can be really large, like a dinner plate size, and persist for a long time. And we're often weaning the medicine in patients with such significant reactions. Urticaria, generalized rash, can occasionally occur, but that's much more common with a systemic drug like eptinezumab compared to medicines like fremanezumab. Even then, it's very rare and usually not at the relatively mild end of the spectrum, rarely dangerous. Constipation, GI disturbance can occur. There's very rare potential for hair loss. So in my practice, I put that hair loss or hair thinning, I put that at around 1 in 2 or 200-ish. And all these drugs can, in individuals, lead to headache change or worsening. not just in the days after you get the injection, but sometimes for the first few months of treatment, even if it proves helpful. Rarer theoretical concerns. Raynaud's is a real concern. So people who are prone to Raynaud's phenomenon, you'll know it if you have it. It's a thing where one finger can go white and blue and red. Talk to your GP if you're not sure. That can make that worse, and it can even hospitalise people. There's a theoretical risk about its influence on the immune system. And many of us are wary of using it in people with autoimmune conditions or malignancies because it could interfere with immune surveillance. So that's a conversation to have with your neurologist to flesh that out. There are lots of qualifications and caveats, which we won't get into today, not the right time, but I've got many patients with rheumatoid arthritis, for example, where I use the MABs successfully. Sleep disturbance, anecdotally, can occasionally occur. Mood disturbance can as well. And one of the things we worry about with these drugs is in their long-term use, could it potentially lead to some cardiovascular side effects? So, for example, in 20 years, will we work out that, people on fremanezumab, they're not quite as good at keeping their coronary arteries open when the arteries are a bit narrowed, and maybe slightly more prone to having a heart attack than not. So that's a sort of theoretical risk. There's no signal from millions of people using this around the world so far. So that's all very reassuring. But it's something we're worried about, just like it could have a theoretical effect on bone health, but we're not aware of any. The GPANs, the only one we have available in Australia at the moment is Rimagepant. And I've got two slides from two different studies talking about side effects. Nausea occurs in a small minority, around 2% of people compared to 1% in the placebo arm. UTI, the data is not compelling, but maybe slightly more risk of it. So that was in an acute setting, and in a different study, more obvious difference with 2% of people with nausea again, but far less than 1% in the placebo arm. No serious adverse events. We worried about liver dysfunction with the GPAC class of medicines because the first generation had that problem, not the new generation, so it's not an issue. Botox, widely used for migraine prevention, 31 injections around your head, can cause some cosmetic change and is a bit practitioner dependent, especially slim people with thin necks. I'd probably rate the chance of feeling the head's a bit heavy after injections around 1 in 50. That kind of thing. It does wear off though, but if you do get side effects, they come on over a week and then that'll settle over a couple of months. Occasionally people report flu-like symptoms with Botox, and the biggest thing to warn people of is that headache can change in its nature, just shift around, move around, be a bit different in the first few weeks especially. Procedural discomfort is an obvious side effect. Just coming to the end of the talk now, I'm going to leave you with a couple of questions. This is one I sometimes get from patients, and it's certainly kicking around the internet. I'm not going to answer it today, but you'll have to tune in to the Q&A. Another question people ask around the safety of particular drugs related to their medical condition, for example. So we'll be able to flesh that out in the Q&A. Hope you can join us then. Thanks so much.
Thank you so much, Dr. Eller, for that fantastic presentation. It's great to have you here for the Q&A. We've got some fantastic questions coming through. Thank you, everyone, for submitting your questions and voting. So to kick things off, we have a question here from Jane. This isn't necessarily related to medication side effects, but perhaps for people who are trying to avoid medications that they've had side effects from. Jane has asked what type of magnesium is recommended for people with migraine. She says that she uses citrate, but she's heard glycinate or orotate mentioned as well. Do you know anything about this?
Okay, so there's no good data to recommend any specific formulation of magnesium. Many of the studies came out probably 20 years ago, 15 years ago, There is a moderate amount of data to support it. It's just not compelling. But there are individual people who do report good response. So for people who don't want to try Western medicines, it's a great thing to try. Usually, different formulations can have more or less side effects. So, for example, magnesium oxide will cause a lot of diarrhea. So there are some formulations relatively more bioavailable, like magnesium glycinate and citrate. But citrate, for example, can be poorly tolerated with diarrhea. So there are several products around Australia. Some are combinations of different magnesiums. Usually it's not just naturopaths that recommend this drug, but most neurologists will just tell you to go to the pharmacy and get some magnesium and not be any more specific than that. I must admit, my recommendation, so this is a bit, I know we've got a lot of questions to get through, but my recommendation over the last couple of years has been magnesium threonate. The brand name for that is Magtein, Magtein. And the reason I recommend that is it was developed in the States to get past the blood-brain barrier better, like get into the brain better. And it was studied in Alzheimer's dementia. So that's something I recommend to people. You can't buy it in Australia directly, but you can buy it on some commercial websites. I don't want to sort of do plugs for them, but a couple of popular ones that some of my patients use are like I don't know if I should even say.
No, that's all good. But
Let's
there's
park it
plenty of
there. People
yeah.
can Google it.
Yeah, no, thank you for that. That's great to know. So the next question is from Robert, and he's asking what have been the ongoing results of the 3 new-ish drugs released in the last 18 months or so. So I believe, correct me if I'm wrong, but I think Robert is referring to Vyepti or eptinezumab, and the GPANs, atogepant and rimegepant, or Nurtec, and I can't remember the brand name for atogepant off the top of my head, sorry. But yeah, what of those, how have those
I've got limited experience of atogepant, for example, just because it hasn't been released in Australia yet. But the safety data that I've seen around the pivotal trials look very good, and that's used both as a preventive and acute. Same with rimegepant. I showed you 2 of the pivotal trials. While I was, I didn't want to watch myself talk again, so I did a literature search again and found a paper that just been published on, which is available through PubMed, on longer-term side effects of rimegepant, particularly in relation to cardiovascular risk. So they triaged how many cardiovascular risk factors people had. So what I mean by that is like high blood pressure or diabetes, smoking, and whether the incidence of cardiac endpoints like heart attack are higher in people who've got relatively more cardiovascular risk. And that just pertains to that last point I was making around some of the theoretical concerns about calcitonin gene-related peptide modulator drugs. And yeah, there's no increased risk, at least for patients that take rimegepant. The other thing to mention is this is more anecdotal at this point. So we're waiting for bigger observational studies to back this up, but some of them have come through that are relatively small, showing that medicines like rimegepant can be used safely in patients who are already on fremanezumab or eptinezumab. In relation to eptinezumab itself, ongoing follow-up of the original cohorts and the original studies, I think, is ongoing. It hasn't been published, but I expect we'll see good 5-year data for galcanezumab, fremanezumab, and eptinezumab over the next year. To comparable to what we've already seen for erenumab, and I think it'll prove reassuring. That's been the real world experience.
Yeah. Oh, well, that's really great to hear. And the next question is kind of twofold. So Rodney has asked how many max salt are safe to have per day, and he's also asked if there are any like other painkillers that help with migraine, because he'd like to have a break from max salt. So can you comment on that at all?
Yeah, so max salt you can use up to 2 per day, so 10 milligrams up to 2 hours apart. That's the recommended dosing. Same goes with all the triptans. Some of you might not realize sumatriptan, you can actually use 100 milligrams rather than 50 milligrams. So that's worth mentioning. You can use, and it's hard to find 100 milligrams over the counter or it's not always on the shelf in the pharmacy. So yeah, 1 or 2 50 milligrams sumatriptan, and then another 1 or 2 2 hours later, that kind of thing. So in terms of acute treatment, that's a whole talk in itself, but the usual thing is, depending on your tolerance to different medications, something like a non-steroidal anti-inflammatory drug, a triptan like Maxalt, perhaps an antiemetic pro-motility agent like metoclopramide, perhaps another antiemetic like ondansetron, and perhaps a GPAT drug like rimagepant. And it could be all or 1 or 2. So most people you just try and find a toolkit that works for you. So it might be, and it might be that, something like elatriptan is very helpful, but makes you feel drowsy. So you only use it at night. And during the day, Maxalt's useful 50% of the time, but it doesn't make you drowsy. And it's well tolerated. And maybe you have too much gastroesophageal reflux, and you avoid non-steroidal anti-inflammatory drugs completely. So you just don't use any of them. So it can be like that. So you've just got to try and play the field of what's available and try and work out what works.
Yeah, it's definitely a very complex process finding that balance between all the different options out there. The next question from Vicky, she asks if tinnitus is a side effect of any migraine medications. Have you heard about this?
Not that no, I don't think so. Not that I'm aware of. I mean, that of course doesn't preclude someone going onto a new drug and then developing, high pitch ringing in the ears. That's tinnitus or tinnitus. And that kind of thing. It doesn't mean that it's impossible. And if you notice something that's really interesting, sometimes what I've noticed in patients, for example, if you get worsening of migraine, you don't tune out from the tinnitus as much, and then it can be more intrusive and uncomfortable. So that's what I've noticed in many patients with migraine. You just can't gate it out in the same way you could prior.
Yeah, no, that makes sense. Thank you. The next question, these two are actually quite kind of related. Elizabeth and Leonora both ask about effects from long-term use of triptans, and Leonora's question was specifically about long-term effects on blood vessels. I know you spoke about that a bit during the presentation, but yeah, if there was just anything else that you wanted to add to that.
Yeah, no, that's a really important one. People worry about that. I'm not aware of any long-term risks of using triptans insofar as the cardiovascular system goes. That's the broad statement, just around vascular health and vascular tone. The more narrow statement is it's a weak vasoconstrictor. So if you know that you have some degree of coronary artery disease or peripheral vascular disease, you've had a stroke, that kind of thing, it moves the blood vessels around 10% for most people in general. So, you should avoid that class of medicine if you know that you have those problems. If you don't have those problems, and many people with migraine who are relatively younger, in particular, that it's just not an issue. Yeah, if you're using triptans 10 days a month, twice a day for 10 years in your 20s and 30s, I wouldn't expect any issue. And this is in marked contrast to the ergotamines in the past. Some of you will remember dihydroergotamine. Cafagot was much more widely used. DHE tends to be just a hospital medicine, but Cafagot was used in a very widespread way in the 80s and 90s and 70s. So that tended to be a nasal spray or suppository. And ergot-derived drugs can cause fibrosis of heart valves and of the space behind or deep in the body. So that could have a lot of long-term side effects, and there were increased risk of things like stroke and heart attack with those drugs used for years. So triptans are really different medicines, and they were a game changer when introduced in the 90s.
Yeah, it's always great to see like a continual progression of medications getting better. So hopefully that continues. The next question is from Karen, and she's asked that I've heard that CGRPs have actions throughout the body, including the immune system. Could immunity or wound healing be affected by Emgality, Ajovy, or any of the other CGRP medications?
Theoretically, it could. So when you look at all the different body systems that where CGRP is a component or it's influenced by CGRP, it's most of them. Many of them. And it's almost remarkable that we can use these drugs and not have problems. So, I mean, there was a case series that was published by neurologists in Australia where we looked at a few cases which were more or less compelling around autoimmune issues that looked like they were related to those class of medications. And the most compelling one was my patient, who unfortunately had a autoimmune hepatitis within days of an around injection. So, and that was biopsy confirmed, and he had a distant history of rheumatoid arthritis 15 years earlier. So that was rather compelling. So I mean, we published that series, but internationally, it's not something that people. I mean, it hasn't been published in the higher impact journals. Many eminent neurologists that prescribe in really big headache centres aren't worried, don't think it's a concern, don't warn patients about it. I'd put it in as a theoretical concern, and any of my patients that have autoimmune disorders or where immune surveillance is particularly important, like if you've had a recent diagnosis of a malignancy, it's certainly a theoretical worry and something to discuss with your neurologist. But the data isn't there to suggest that it is a worry. It remains a theoretical worry, just like around wound healing. So that was cutaneous immunity and propensity to adequate wound healing. The CGRP is involved in a lot of those systems, and it struck many people, especially in the early days, that there could be a theoretical concern there. Hasn't been proven. But, you know, there will be some neurologists around Australia that will warn people who say, oh, well, you know, get your hip done. And then a few months later, we'll start you on, you know, fremanezumab, whereas other people, the neurologists, won't discuss that in practice.
Yeah. I mean, I guess it all goes back to that at the beginning of your presentation, talking about like finding that individual balance based on everyone's concerns and risk profile and comorbidities and everything. So yeah,
for sure. I think that your neurologist should be prepared to have a discussion around it and not sort of close the book on it, or you can just talk about where there's more or less evidence and try and have a lucid discussion. And, you know, for some people, even theoretical risks they're not prepared to take. And I like that just needs to be part of the conversation.
Yeah, no, definitely. Okay, well, the next question is from Eliza, who asks, if treatments haven't been 100% effective in the past on their own, are they worth trying again once you have some success with something like Botox? So I guess layering multiple treatments.
Yeah, this is an old chestnut, like monotherapy versus a number of medicines. The short answer is yeah. I think that's certainly the case. Wins in migraine can be really hard won, and for some people, they've tried 10 different treatment, 10 different drugs or treatment modalities. Maybe they get moderate but very useful benefit from Botox, for example. Like this patient. And if you've had something where you've had moderate success in the past, maybe with dose limited because of side effects, maybe small dose of nortriptyline at night or a modest dose of topiramate was, moderately useful. Yeah, if you've already explored the other options, for sure, it's potentially worth adding it in. You might do even better.
Yeah.
The,
And on
sorry, yeah. Just one little point. The thing I'd get wary about is some people do perceive some benefit, like small marginal gains, and you can get into the cycle where you just hit layer, and then before you know it, you're on 4 or 5 medicines, and every time you try and wean off one of them, things get worse, and you get a bit pickled with a lot of side effects. So that can be a trap that people can get into, and it's not always in their interest. So more is not always more.
Yeah, of course. Okay, yeah, that makes sense. In the same vein, I guess, Leslie asks, I guess, almost like the inverse question, about revisiting a previously tried drug. They say that they had success with propranolol, and then it stopped being effective, and so now they're wondering if like they should revisit it. Is that something that can change, like fluctuations in how you respond to a medication?
I think so. I think it sort of depends on how durable that perceived benefit was, back in the day, and how well tolerated it was. But if it was a well tolerated drug and there was benefit for several months or a few years, and then it sort of stopped being compelling. Yeah, I mean, in a different context, different time of your life, particularly if you've cycled through several other things. If that's the one that you sort of think back to and think, oh yeah, I was all right on that in hindsight, it can be worth trying, because you can lose sense of your baseline. You have a particular headache predisposition, headache and migraine predisposition, burden associated with that, and the way you live your life within that for weeks or months. And then that starts to feel like the new normal. And then you can forget what the old normal was like. So, yeah, like I think if it's, if your lived experience had said, yeah, that was interesting and it felt different on that and it felt better, it could be worth revisiting.
Okay, that's great. The next question, this is also circling back to triptans. And I'm not sure if we covered this, but just in case, an anonymous attendee asked if people over 65 can continue to take triptans if they don't have any cardiac disease. Like, is age alone enough of a risk factor to make it something that you should maybe avoid? Or does there need to be like actual, pathology but underlying that?
I mean, people would have different approaches to this. I would say, age is no barrier.
Okay, that's wonderful. Great. And the next question from Doni is they're wondering if there's another alternative to Imogran nasal spray. I know this isn't specifically about like side effects, but it has been something that's come up a lot in the community since it was discontinued back in February, I think. So yeah,
Yeah,
a lot of people are wondering.
it's tricky. We don't have an intranasal formulation for people who are vomiting. How are you going to get the medicine into you? I know Zolban as a nasal spray is available overseas. I'm not aware of it being in Australia, but I've heard rumours that some people have somehow managed to access it, perhaps through special schemes. I haven't managed to do it myself. So it's a bit cheeky to even mention it, but I mean, that drug is available overseas. It's a shame we don't have it here, at least easily available. Maxalt for some people can be helpful because it's an intrabuccal sublingual drug, so that's easily available. So if you're vomiting, you can handle that. For some people can handle that. Rimagepant is an orally disintegrating tablet, so for some people who are vomiting, they can handle that. And Clustran, which is a brand name for subcutaneous sumatriptan, which is still available even though Imigrane isn't. That's another alternative. None of them, but it's a loss that we don't have sumatriptan as a nasal spray. The injections are hideously expensive. There's another nasal spray which a compounding pharmacy can potentially make for you, although not all of them do it. That's called dihydroergotamine, but that has its own problems that can make people feel nauseous. So you usually need to pre-medicate, and the compounded formulations tend to have a shelf life and need to be kept in the fridge, and they're expensive. So problematic, but can be useful.
Well, hopefully there's a manufacturer that decides to bring something over, and with some advocacy, hopefully we can get there.
I hope so.
Yeah. The next question is from Glenn, asking, they've heard that neuromodulators are a promising non-drug alternative for migraines. Is this true, and what do you see coming that's exciting?
Yeah, neuromodulators for sure could be useful. In Australia, we have two that are on the market. One is the Kefli device, the supraorbital supratrochlear stimulator. It sits here. If you Google CFALY, you can see it. There's another device called the GammaCore device, which is marketed by one company called Medistar, based in Brisbane. It's a much more expensive device because it's almost a subscription service. It's a vagal nerve stimulator. Both of them have evidence base. Kefli more for migraine, and GammaCore, the weight of evidence is actually better for cluster headache, especially episodic cluster, than migraine. Occipital nerve stimulation has been TGA approved, or has been approved for use in Australia for several years. That's helpful in around 50% of people, but it's invasive, expensive, and really a last line potential therapy for chronic migraine. And it was bedeviled by all sorts of problems. So it's lost its CE mark in Europe, for example, because what I'm talking about here is a battery box that sits under the skin with a stimulator in it, a pulse generator, and a wire that's tunneled under the skin, and then wires that hit the great occipital nerve at the back on both sides. That is, so many lead migrations or revisions. It was just really problematic. The newer versions of that are better, but extremely expensive, very operator dependent. In the future, what we all hope to see, and there are trials of different devices around, are machines where the pulse generator in the battery will sit above the neck, so it'll, not below that very mobile joint, and it'll be very discreet. Maybe you recharge regularly, and will stimulate perhaps the great occipital nerve and the supratrochlear nerve, for example, or the auriculotemporal nerve, or all of them. So I think we're going to see a lot more of all of them, and the data for all of the ones that I've seen so far are very reasonable. So there's a strong and principled basis for these things, and they'll, for individuals, they'll help.
Yeah, no, that's very exciting to hear about. We are nearing the end of the session, so I just want to get through a couple more quickly. We've got one here from Fiona, asking if for Emgality, is there a recommended length of treatment, and also asking about hair thinning. And also, just while we're on the topic, I saw a lot of people asking in the chat about bone density and osteoporosis. So yeah, I know that's a bit of a complicated
Okay.
question.
Yeah, so like, well, galcanezumab for chronic migraine or episodic migraine under the PBS, you need to try it for 3 months to see if it's helpful. That's a loading dose of 2 injections and then 1 per month. I mean, there's a subset, maybe up to 10% of people who would respond in the next sort of 2 to 3 months, but we can't capture them in Australia under the PBS. So in terms of hair thinning, I think, like I mentioned in my talk, I think it's probably around 1 in 200 people. And the people that I've seen with it, the hair has gotten back to normal when they stopped within months. But, you know, there's not enough longitudinal data to really say that'll happen in everyone. We just don't know. And I certainly can't pick who's going to have that issue. But I can tell you that 2 patients of mine that were both hairdressers did have the problem.
Oh,
and they were quite convinced. I believe them.
Yeah.
In terms of osteoporosis, that's a theoretical concern. So they're actually studying that at the Alfred Hospital in Melbourne.
I think we
They've done
funded a
some initial
grant into that,
studies.
actually. Yeah.
Yeah, so that's just I think I mentioned it. It's a space where there's a theoretical worry. Initial data isn't a concern, but you know, it's sort of space where we need really long-term data.
Yeah. Okay, well, I'll just try and get one more question in quickly. The next one is from Jane, asking about serotonin syndrome and migraine medication. So, for example, with like antidepressants, is there any risk of that at all in migraine medications?
Very low risk. The main thing to cover here, and it's an important one, there's a black box warning around triptan class of medications, so like sumatriptan or rizatriptan, and antidepressants like SSRIs or SNRIs. That is a spurious black box warning. All pharmacists will warn you of it. Your GPs will be worried about it. The data doesn't back it up, and the theory around it doesn't back it up. Having said that, can serotonin syndrome occur in individuals? Yeah, there are some serotonergic medications that people with migraine use, like pizodopin, for example. So if you're on high doses of tramadol, pizodopin, you're on some nortriptyline, and maybe a really high dose of venlafaxine as well, and a couple of other things, perhaps. Yeah, there's a potential risk. It can happen, but like for commonly prescribed things for migraine, very rare. Your only real worry should be is if you're on a number of different medications for psychiatric trouble, plus minus some painkillers, combination of all of the above, then you can start to get into that kind of territory.
Okay, great. Well, thank you so much for all your time and the fantastic presentation and answering so many of these questions tonight. It was such a great session, and we were so thankful to have you here.
Well, thank you for the opportunity, and thank you, everyone. No, you guys are amazing that you organise this. Great.
Yeah, no, it's such a wonderful event every year, and I'm so glad that yeah, we get to connect with everyone in the community and answer so many questions. Everyone, tomorrow night the session is on other types of disabling headache. So if you're interested in that, please tune in. And otherwise, enjoy the rest of your night. Goodbye.